Hey, here I am. 1 minute early. Oh, I'm not even looking at the right thing. Here's the camera. Welcome to my live stream. Oh, yay, I can see your messages now. Um, whoop- Whoops, what happened? Hold on. And I've got to turn off. There we go. I had the channel up, and so it was doing it. And that was weird. Anyway, welcome again. Thanks for coming. I see I already have lots of questions. Um, the way I was going to do this was I was going to give you a couple of news items. That was just to have something to talk about in case no one had any questions. But of course, you do. But I would just want to say hi to a few people before we really get started. Hi, Luke. Thanks for coming. Isn't this cool? I now have software to be able to like see stuff and put things in the chat. Hi, Kenya, Daniel, Joe, Agnes. Um, so the way this is going to work, and I have a moderator this time as well, who will get rid of any chats or comments that are not nice. So mean things, sub stuff, all that kind of stuff, even though I'm not even sure those kind of comments will come through, because generally YouTube sees those as spammy comments. So at any rate, that's the logistics of that. Also, I will be, after the stream posts, we will go back in and timestamp questions so that you can easily find what you want to listen to. So my goal or plan today is to go for an hour, and let's just see how many questions we get to. But I do want to announce a couple of things. I mean, these aren't like personal announcements. This is more like psychiatric news for those interested. So I do, let's see, this isn't. So I'm officially starting here, and I'll go back to the chat after I say a couple of things. So there's a new TMS protocol. TMS stands for transcranial magnetic stimulation. And it's a treatment for treatment-resistant depression. There's actually a protocol also for OCD, which is really good because it's not always that easy to treat OCD with medication or have the symptoms completely go away. So one of the issues with transcranial magnetic stimulation, and it's kind of, you can think of it as a substitute for ECT or electroconvulsive therapy, the shock treatment from back in the day, although we're still doing it today. The TMS requires you to go in. It's generally a 6-week length of time that you do it, and you go in 5 days a week, which is pretty time intensive for someone to have to go in every day for 6 weeks. So now they have a new way of doing it where you can get that same 6-week benefit in just one treatment. So for those if your doctor has mentioned this to you before or you've thought about it before, just know that I'm not sure how available it is yet and how much they're using it, but that at least that's somewhere in the pipeline if they're not already doing it. All right, then another thing is there's a new antipsychotic medication for the treatment of schizophrenia called Caplyta. And it came out in late 2019. And I think because of COVID and all of that kind of thing, it's been hard for people, the drug reps, to introduce it to the doctor. So I still have yet to have anyone talk to me about this. And as such, I have not used it yet. But they tested it head to head with risperidone, and it's a little different because it doesn't act at the dopamine receptors. The significance of that is that you don't get the stiffness and what we call akathisia with restlessness and having to move and things. So that's a positive. The jury's still out, though, on how good it will end up being. A lot of these antipsychotics will be tested or used also for bipolar disorder. This, as far as I understand it, has only come out for schizophrenia and not bipolar disorder yet. Okay. And then the last thing before I get to your questions, as far as kind of psychiatric news, there's also a new sleeping aid. And there was a question in the chat about sleep suggestion or sleep medication suggestion. So this kind of ties in with that, but I will get to that question. And the new medication is called Dayvigo or Dayvigo. I'm not, probably for vigor, so maybe it's Dayvigo. And it's similar to the medication Belsomra, and it works a little differently from the medicines like Ambien and Lunesta, because it works on the aspect of sleep. It works on wakefulness. So there's kind of a balance with sleep. There's your ability to fall asleep, and then there's the chemicals in your brain that keep you alert and awake. And there has to be a balance between those. So during the daytime, the wakefulness promoting agents are more present, keeping you awake. And then at nighttime, those kind of get suppressed, and then the sleep enhancing chemicals take over. So it's thought that insomnia, that the bigger problem with insomnia is wakefulness, the brain chemicals that promote wakefulness intruding into your sleep. So Belsomra and this one work at orexin receptor, for those of you who may know more about this. And that's one of the brain chemicals that is responsible for wakefulness. So long story short, this is another one of those medicines. My experience with Belsomra has been kind of mixed. I've had some people really like it and get benefit from it. And then I've had others that didn't really like it. Because it's branded, meaning it's not generic yet, it's expensive. So if you don't have insurance, it may be cost prohibitive to take it. It's also not a knockout drug. That's what we call the drugs like Ambien that make you fall asleep. It is one that's supposed to help you stay asleep. So that's new on the horizon. And then lastly, also, I wanted to put on a shameless plug for my calendar. Don't forget about it. My 52 weeks of self-improvement. Even though we're halfway through the year and June, you might feel like, well, I don't need a calendar at this point. It still has very useful self-help tips for every week. So this month for June is mindfulness. And so I give suggestions each week of things that you can do to practice mindfulness. And one of them, for example, for this week, we're still in the first week of June, is take a 5-minute break and observe your breathing every day. These little short breaks in the day can really go a long way. I mean, that might seem like hardly anything, 5 minutes, but it can go a long way in breaking up the tenseness of the day and decompressing your day to help you relax and even purge some of the clutter in your mind. All righty, so let me get to the questions here. Thank you guys for coming again. I wish I could see you. I wish this was more like a Zoom thing. All right, so let me go up, starting kind of near the top. And I'm gonna try and get to as many as I can. Of course, it's easier to answer ones that are briefer. So let me just take a sip of water. All right, so Agnes says, let me put Agnes's question here. How do I do that? There we go. Hi, Dr. Marks. Hold on, something's in my way here. Okay. Hi, Dr. Marks. I'm currently living in Taiwan. It's not easy to look for help for those who suffer PTSD. Sorry, I'll get it. I'll get this. This is only my second live stream, so there's going to be lots of little blips and mistakes here. All right. It's not easy to look. Now, where did it go? See? Where did it go? Did you take your question away? Okay, I lost that. Oh, no, here it is. Okay, thank you. All right, here we go again. All right. Hi, Dr. Marks. I'm currently living in Taiwan. It's not easy to look for help who suffer PTSD in Chinese society. Is it possible for you to have a topic for it? Thanks a lot. I have one video on PTSD, comparing it to CPTSD. You can search my channel for that. It was probably last year, so you may have to scroll way down because I don't have a PTSD playlist. But yeah, I could add some more. Trauma treatment really isn't my area of expertise. There's a lot of, there's a lot of different treatments for trauma, and it depends on the kind of trauma and things. And so, but yes, I could talk more about it. And I'm sure you could also find some YouTube videos on it as well. All right, let's see. Okay, here's a question from Seti. Hi, Dr. Marks. I'm 34 with a history of depression and severe anxiety. I lost my father to coronavirus 2 months ago. I'm taking sertraline and Topamax and clonazepam, but I can't tolerate this life. I'm really sorry, Seti. I know that the coronavirus has hit this nation, world, in a huge way. I don't think we fully appreciated the impact of people being sick in front of you and dying in front of you, especially for those of us who haven't seen it firsthand, unlike perhaps someone living in New York City or a city where it's more concentrated and you can see them building places and graves in the park and things like that. But even just the impact of an individual loss, of knowing someone who has died, it's very hard to accept. And if you already are vulnerable with depression and anxiety, it makes it even harder. I know that as time is passing, there's been more resources online of people having like discussion groups and kind of support groups to talk about this, people living with the loss. And that's what I would suggest. If you could research online, there's lots of things popping up. Even things just as, small as exercise with me and cook with me. There's also the talk with me and let's talk together about this. There's some Facebook groups. In fact, there's a Facebook group that I am a part of, that I joined, called Living with Coronavirus on Facebook. So there's lots of self-help support type of groups out there that I'd suggest you join in to help process some of this. Okay, let's see. Here's a sleep question from Nick Hill. Sorry if I mispronounce it, or Nikhil. Currently, I am taking Zolpidem 5 milligrams for sleep, which gives me too much sleep. Which tablets shall I ask my doctor to start for instant sleep? It should just give me a sleepy feeling, not too much of sleep. Okay. So this is a good question. It ties back to what I was talking about with the sleep medicine. So getting a medication, the ideal sleeping medication is one that helps you fall asleep quickly, sleep deeply for just the right amount of time, wake up feeling refreshed. And none of them do that perfectly. Some of them do it better than others. So the medicines like Ambien, Lunesta, what else? There's Sonata, but not quite so much as Lunesta. So Sonata is another one. But Lunesta and Ambien are more popular. Zolpidem is Ambien. Zolpidem is the generic name. Lunesta, the generic name is S-zolpiclone or something. I never say it. I always say Lunesta. So those medications are very good at helping people fall asleep pretty quickly. I will say, though, one thing that is important if you're taking that kind of sleeping medication to help fall asleep, they tend to work better and faster on an empty stomach. So if you eat a big meal and then take your sleeping pill, it may take a few hours for it to work because the full stomach delays the absorption of it. So what is an empty stomach? I usually tell people somewhere between 2 to 3 hours since you've last eaten. So keep that in mind. Also, what you want to do is you want to make sure that you are ready to go to bed for these pills that have more of an instant or knockout effect of making you fall asleep or get very drowsy. Because some of them, when you first start taking them, you could take zolpidem, for example, and be talking to someone on the phone and just all of a sudden start saying crazy stuff and pass out. And then the next day, the person's like, what was wrong with you? Because you took your Ambien and just thought you could have a conversation with someone. So sometimes it can work just like that. And then after a while, your body gets used to it. It takes longer, and then what you eat could make a difference. So you want to make sure you're ready to go to bed. But as your body gets used to the medication, it can get to where it has less of that knockout effect, and it becomes more like this floaty feeling, like you can tell if you go lay down, you'll fall asleep. And you could actually work through it and end up losing that moment of opportunity to go to sleep. But I've had a number of people tell me that happens. Like they take it, they start feeling like they could go to sleep, but oh, wait, let me just go do this one thing. And then they're finished, and then now they're not sleepy anymore, and they can't fall asleep. So that addresses kind of the instant aspect of it. Not all of them are instant. So I would say zolpidem and the Lunesta are as close as it gets to instant. And some of them, and so the more instant they are, the shorter acting they tend to be, and you can end up not sleeping very long and end up waking up or waking up a few hours later. The longer acting sleeping aids tend to not work as fast, but can kind of knock you out for a longer period of time. And that would be things like trazodone, which is an antidepressant, but we tend to use it more for sleep because it's a sedating antidepressant. Doxepin is another one. It is also it's a tricyclic antidepressant that we pretty much don't use anymore as an antidepressant. The tricyclics in general have fallen out of favor because they have a lot more side effects, and we have more options these days. But doxepin in small doses, 10 milligrams is the smallest pill size. They came out with a sleep aid called Silanor that is in 3 milligrams and 6 milligrams. It's been a long time since I've actually used it. It wasn't marketed that well, or they kind of lost some steam behind the marketing, so it's not that popular, but it's there. In doxepin, if you use that's the generic, the easiest access one is doxepin 10 milligrams. That can be kind of a bit heavy. So it has it's a sedating antidepressant. So it hits several different kinds of receptors. And when medicines hit different receptors, like the histamine receptors and the anticholinergic receptors, we call them dirty drugs because they're not as narrowly focused. So you get these other effects. Well, here we like the effect of the sleep, but you can get all kinds of other problems with it, like a hangover effect in the morning, and feeling too tired all day long. So that's one option, but nonetheless, that's a potential downside of it. And then other antihistamines, there's over-the-counter things. And the antihistamines are usually the over-the-counter options for sleep. And then hydroxyzine is a prescription antihistamine that you could mention to your doctor. And we use it for both anxiety and sleep. It's sedating, particularly if you take it at night, but even during the day, it can be calming. And the doses for that range anywhere from, usually with anxiety, it's between 50 and 100 milligrams, but there are smaller size pills like 10 and 25 milligrams. And, though it can be, I have had people say that it's very tiring for them all day long. So it takes a lot of hit and miss and experimentation with the sleeping pills. There's no perfect instant out sleep as long as you need, wake up, you're ready to go. Like, none of them work that way. And they eventually start to get to where they're not as effective after a while, and you have to take a break from them. All righty. It's my long answer about sleeping medications. All right. Miss Amy says she's grateful for the effort. Thanks so much, Miss Amy. I really appreciate you. Let's see. But I didn't get to your question. Let's see if I can see what it is here. I hope you talk about how to help people with avoidant personality. Miss Amy, that would take me too long to answer that question. That's more of a longer form video content type of question, because it's just not a quick answer. And so with that, so the answer depends on what is the behaviors that are causing problems. And it's not one thing for every person. So someone with avoidant personality disorder, usually, so the person craves or wants the intimacy and closeness with people, but have all of this fear around feeling shamed or embarrassed or judged by people. So that's a huge block to doing the things to be in a relationship or to put yourself out there. So the real help would come in looking at the details of what are you doing? What are you not doing? What are your pain points? Because for some people, they may be able to do this. They may be able to say, oops, I hit my microphone. Sorry. May be able to go to a friend's house, or they may be able to go to parties or something if they know they're going to know everyone and stay there for an hour or so. But then they got to leave, and when they get home, they feel depleted, etc. Versus the person who has complete is just staying in the house, never going anywhere, and home miserable, even though they really want to reach out with people. So it kind of depends on how much it's affecting you as to what the answer is to what to do about it. I do think I would say take a look at a video I did on social anxiety, which is similar but not the same problem. And I talk about gradually exposing yourself to things that make you anxious. And I talk about the fear ladder. That is a similar exercise that you could do with avoidant personality disorder. So take a look at that. All righty. Thanks for these questions. Let's see. We got Dennis says, can untreated psychosis lead to dementia? Untreated psychosis leads to dementia. No, not really. And here's why I hesitate with that. So psychosis can be present in a variety of problems. The primary disorder that it comes along with is schizophrenia. But with schizophrenia, there are cognitive problems. There's cognitive impairment with it. It affects your thinking. That's why schizophrenia is a bigger problem than just hearing voices or just psychosis. So people with schizophrenia can have a slow decline in their cognitive abilities over the course of their life and the course of the illness. And certainly untreated episodes of it can make the overall functioning worse over time. So that's an indirect way untreated psychosis can affect the person's thinking and cognitive problems. Dementia really is impairment in various aspects of cognition. So that includes memory, that includes naming and recognition, that includes problem solving and analyzing. There's various aspects of dementia. So where was I? So as far as other reasons for psychosis, like bipolar disorder and having a manic episode or a depressive episode and becoming psychotic during those periods, we know that untreated psychosis is bad for the brain, and it does have longer term effects. At this point, I don't know that we fully understand the scope of the damage that it causes and what that looks like at the end point. But we do know that for, say, going back to bipolar disorder as the example, let's just say depression, psychotic depression. If a person repeatedly stays psychotic without getting treated, it makes the depression illness worse. So you can have more and more episodes. We call it the kindling effect. More untreated episodes breeds more episodes in the future that get harder to treat. So that's kind of an abbreviated answer. I could go on for a while about this, and I won't, but that's an abbreviated answer to, can untreated psychosis cause dementia? It can certainly worsen illnesses, and yes, we know that untreated psychosis causes damage to neurons. I don't know that we know the full scope of what that looks like. Thanks for that question. I was actually going to do a video on that. I still might, but I need to do a little more research, particularly in the area of, do we know yet? How much do we know about the long-term consequences? I want to get some more information on that before I do a video on it. So you're getting ahead of me. Thanks. Okay, so we got Miss Amy. I think Miss Amy, is this your second question? Can depression lead someone to hate their spouse and seek disconnection and isolation from them while still maintaining contact with the rest of the world, even though on a shallow level? That's an interesting question, Miss Amy. Yes, is the short answer. Can depression make you hate your spouse? Well, there's a lot of things that can make you hate your spouse, but I guess if you're asking, can depression make you single out your spouse as someone that you focus your anger toward? Yes, because your spouse presumably is someone who's there with you all the time and potentially triggering you, triggering episodes, getting on your nerves for various reasons. So it's easier to take out your aggression, anger, irritability on your spouse and anyone close to you in your life than it is on someone outside of your life who may retaliate more. You show up at work lighting into people, they're just not going to take it, or you could lose your job or something. There can be more detrimental consequences. So even the depressed person has the ability to gauge or to adjust their behavior to be able to meet the goals that they need, like keeping a job, maybe keeping some friends or some level of support outside of your home. As far as the hating your spouse, though, I think that the way I would connect those two is if there's a longer backstory to a difficult relationship with your spouse and resentments and things like that, they're already in the background. Now you're depressed and your negative focus turns toward the issues that you already had with your spouse, and it gets magnified in your mind. And then, yes, you can have shallow relationships with other people because there's not enough information, there's not enough things that they're doing to bother you enough to hate them that much. Because with hate, I know that people will say the hate is the opposite of love, or that indifference really is the opposite of love, but that hate is an intense emotion. There's got to be some emotional investment with the person to hate them versus someone you're indifferent toward. You don't really care anything about them. So you don't care enough to hate them. So it would stand to reason that people just in your social circle or that you have a loose connection with, that you're not going to hate them like you would hate someone you care about. All right. Thanks for that question, Miss Amy. All right, let's keep it going. Appreciate you guys. Let's see. I am going through. So I'm trying to address a question that, it's easier for me to answer. So something like, help me. I wish I could help, but I don't know how to help just based on that. So I'm trying to address more specific questions. Uh, let's see, and get to more people too. All right, here is, how do I click? Okay. I don't know how to pronounce your name, so I don't want to botch it. So thanks for the question. I've been diagnosed with bipolar 2 and BPD traits, which I'm assuming is borderline personality disorder traits. Is it possible for me to get rid of these traits and be BPD free? Okay. So the short answer is no. It's not possible to get rid of the traits. It's possible to control the traits or control your behavior that is based on the traits. Because think of it this way. We all have personality characteristics. Your personality is your hardwiring that's based on your temperament, your just your general disposition. You can have two, maybe not twins, but you can have babies and see the difference in how one responds to the external world versus the other one being more quiet and reserved, taking a lot to get stirred up, the other one maybe being more fussy and easier to get more curious even. So we're built a certain way, and the way we're nurtured affects how we express ourselves. Okay, so we start with that. If it is a trait of yours to be, let's just take the most popular or the most common, I guess, personality trait with borderline personality disorder being the fearing abandonment. Most people have probably heard of that trait. If it is your inclination because of your personality to be more sensitive to fearing abandonment, it's not as though you can just never think that way. It could get out of control where you have multiple relationships where you're always like everything makes you think this person's just gone tomorrow. You just met this person. He's not going to like me anymore. Or, is he going to call me tomorrow? I mean, and granted, that's a general question you can have. So just because you have that question doesn't mean you fear abandonment. But what I'm getting at is you can have a lot of destructive relationships because you're always questioning and always scared that the person's going to leave, Or you could get to the point where you get past that by whatever means that is, whether it's therapy, whether it's a lot of self-help and things, but whatever it takes for you to rein that in, you can rein it in such that you're no longer pushing people away because you fear that they're going to leave you. You don't do that anymore, but you can still have moments of questioning in your head. But if it just stays in your head and no one else hears about it and you don't act on it, then no harm done. Because we have lots of thoughts in our heads that if you don't act on them, it's of little consequence. So that's what I mean by you can still have traits that make you think certain ways and have certain knee-jerk thoughts. But one of the things, like with cognitive behavior therapy, or let's say cognitive therapy, is recognizing distorted thoughts and being able to challenge those thoughts so that you act differently. You don't act on the assumed thought that's incorrect. But it doesn't mean you'll never think that way. So that's, I think, the best way to kind of think of this is that you can still have tendencies and thoughts that go on in your head, but you can get to the point where it doesn't cause a lot of problems for you. And that's really where the rubber meets the road here is, does it cause problems for you? And if it doesn't cause problems for you, then, you just keep moving. All righty. Thank you for that question. All righty. Let's see. I am, uh, okay, Adnan. Adnan's asked me other questions. Thanks for coming, Adnan. And you know what? And I did not get a chance to answer your questions in the last live stream I did. I think you asked me 2 questions, and I don't remember why. I just didn't get to them. But anyway, here we go. Here's your turn. What to do if you feel unpassionately about pretty much everything and positive activities and socializing feel forced? Oops, let me put your question back up. I don't know how to make them stay a long time. Isolation and doing nothing is also the best. Any ideas? So let me rephrase this so I understand it. You feel pretty much dispassionate about things. I'm assuming what goes along with that is very low motivation, not real low interest in things. And here you're back. And you pretty much have to force yourself to get out. Isolation and doing nothing is also not the best. True, it makes things worse for you, everyone. But do I have any ideas about what to do about that? So one suggestion would be to in fact, I just ran across this in something I was reading not long ago. It was a treatment approach. I can't remember the context, but basically it's experimentation with things. So if you don't have something that you're passionate about, or you don't have a hobby, you don't have anything that interests you, how do you find something that interests you? You just keep trying things. Give this a try, give that a try, give that a try, give that a try. You may have to go through a lot of things. Now, but you're not going to, if there's no exploration, then you're just not going to know, and you're going to sit with all you've got. Now, you might say, well, I'm not even motivated to just try all those stuff. That sounds exhausting. Well, okay, but then that's the problem. Like, that's the part you got to get past. Not, I can't find something. It's, I don't even have the energy or motivation to try and find something. I guess what I would say to that is, so if I were seeing you in my office, because this isn't an easy answer. If I were seeing you in my office, I'd ask more questions about how you're feeling about things in general, to get a sense of, okay, are you depressed? Are you having trouble just kind of finding anything pleasurable because you're depressed? If a person's depressed and lose interest in things, it's not that easy to just say, just get interested. Just watch YouTube till you find something you like. People like that can just sit and people will tell me, the TV's watching me. I'm not watching TV. They can just sit there like they're in a daze and nothing is registering. And before you know it, the day's over. And then they just get up and there's another day like that. That kind of state of mind, I usually recommend medication. I don't think you can necessarily self-help your way out of that low state. Adnan, it doesn't sound like that's necessarily what you're talking about, but I at least wanted to address that issue because, again, if I were seeing you in person, I'd be digging for more information to see the source of this. Is it just pure boredom? If it's pure boredom and not necessarily that you're depressed, let's say you were someone who didn't really do much outside of work. This could be anyone. You get up, you go to work every day, you work 10 hours a day. Life is pretty much work. Maybe you have a family, you do some things on the weekends with them, and, back to work on Monday. So if you lose your job, or your job becomes one where you're not doing much because you're at home and you're just on hold, you don't have anything. And you're not necessarily motivated to just find something. Not everyone has something in their back pocket of, oh, cool, now I can go get into the painting that I didn't have time to do, and like stir up all these projects that you never had a chance to do. That's not everyone's life, and not everyone can do that. So part of what if I'm dispassionate about stuff, that part of that situation could be boredom, in which case I'd go back to what I was saying in a previous question about finding support groups online. In that question, I was talking about support groups for grief. But here, maybe finding a group that's into something that you might think you're into. And as you see the things that people are talking about, Reddit is a good place for that. But as you see the things that people are talking about, it might spark some more interest for you to look into it further. It's about brainstorming and exposing your stuff to as many different things as possible to see if something sparks some kind of interest, or if you can gain traction with something. That's what I would suggest about how to try and find something that gives you some joy. All righty. I hope that answers your question enough, Adnan. All right. Let's see. Here we go. What else do I have here? One thing I can't see, I think I pretty much see everyone in the chat here. Sorry if I'm missing people's questions. I'm just trying to get as much as I can. All right. Modified Station asks, what is the way to get out of bipolar disorder? The way to get out of bipolar disorder. Okay, hold on. So I'm not sure exactly what you mean by get out of. So if you mean no longer have the disorder, that's pretty typical for people to want to know, how do I make this go away and be cured? And I did a video on, I don't remember the title, something like, can you cure mental illness, or can mental illness be cured? I would suggest you go take a look at that for more details, if in fact that's what you mean. But mental disorders like bipolar disorder are not cured and don't go away. They go into remission. Remission just means that you don't have any active symptoms of the illness, or you have very few, such that you're still able to function in things. So all of these things can flare up. I hate this mic like this, by the way, but I tried to do it a different way. I hate that arm. That's like unsightly. I tried to do it above, but anyway, and it was too far. So anyway, these illnesses you can have flare-ups of them, and then just things can just change, and you go into a state where they're not that active. With even bipolar disorder. So bipolar disorder, you have episodes of depression and mania. Some people can have back-to-back episodes of something, either depression or mania, for a few years, and it seems like they can't seem to get out of the episodes. Like they get better, and then here comes another one. And then there can be, and that usually is influenced, in my experience, from people not taking medications or getting on something and then getting off because they don't want to take things, side effects, etc. But that said, still, even someone can take something and it not be the right one for them and it not work well enough. So anyway, person can have like multiple episodes back to back. And then they can have like a quiet period, kind of like the eye of a storm, where not much going on. And that could last years. I have some patients who have seen me, and maybe the first couple of years I was seeing them, they were having a couple episodes every year, and then nothing for several years. And so, and then will it come back like a true eye of a storm? It gets better, but then you gotta wait and brace yourself for that other back of the eye that's going to come through. it doesn't, if it goes away for a while, it doesn't mean that it's necessarily going to come back with a vengeance, but it is realistic to think that it will come back at some point, either a depressive episode or a manic episode. You can get to where the episodes are manageable enough so that you kind of have this like uptick maybe in your activity level with some hypomania, but again, and that's when it's important to stay in treatment with a doctor who can help maybe adjust your medicines if that's necessary. Sometimes attending very strictly to things like your diet. I highly recommend the Mediterranean diet, which I'm still on. It is a diet that has now been studied in people for that and showing that it helps depression. I did a video on that you should go take a look at. It was not studied in bipolar disorder, but to me that doesn't mean a ton. It just means that, okay, there wasn't, they didn't include it in the study. But if it helps depression, why can't it help bipolar disorder or any other mental disorder? So diet, sticking to as strict of a routine as you can. We call this social rhythm therapy. Social rhythm therapy has been shown to be very beneficial and helpful with people with bipolar disorder. And it's essentially sticking to doing certain things at the same time or as much around the same time each day. I usually recommend people find like 3 data points in the day, because the real treatment actually has a bunch of different points and it's not that easy to control all those things. So I tell people kind of a modified form of it would be to have at least 3 data points: the time you wake up, the time you go to bed, and then find something in the middle to also be like I like to think of it as pressing tacks on a board. Tack the top, tack the bottom, tack the middle, and like the little floppy pieces in between those tacks can flop around, but at least you've got these anchor points. So that middle tack could be the time you have lunch or dinner even. I mean, they don't have to be evenly spaced. But so things like eating lunch and things like that, if you work and things, you may not be able to always control when that happens, but you want to pick something that you can control as best you can. You should be able to control when you go to bed. And when you wake up too, if you can get yourself on a good sleep regimen. So sticking to that kind of routine is also something that can help keep your symptoms at bay and keep the illness at bay. So that was a long answer, but the short answer to your question is you can't make it go away completely, but you can make it, push it back, go into the recesses, and stay stable and in remission, so to speak, of having very few symptoms for very long periods of time. And then when it comes out of remission and flares up again, your flare-ups don't have to be ones that destroy you or send you to the hospital, especially if you stay in treatment with someone and use these other behavioral lifestyle things to kind of keep things together as well. Okay. Let's see. All righty. Here's a question from dentist. I need to go to the dentist. That's probably why I said that. Dennis. But I'm scared to go. But anyway, that's a whole nother issue. Can Concerta improve academic performance? Yes, it can, Dennis. So Concerta is it's a medication we use. For those who don't know, Concerta is a stimulant that we use for attention deficit hyperactivity disorder. The 2 main families of stimulants are the amphetamine kind of stimulants like Adderall, Vyvanse, those are just 2, Dexedrine. And then there's the methylphenidate family of stimulants, Ritalin, Focalin. Concerta is long-acting methylphenidate. Anyone can take a stimulant and perform better and do more. So performing better with a stimulant is not evidence that you have ADHD. FYI, I have a few videos coming up. I finally have done it as far as creating the videos with some behavioral interventions for ADHD. I talk about those in a video I did on executive dysfunction. And I said these are coming up. Well, I finally got them out. Not all of them. I still have some more coming. But the executive dysfunction that you have with ADHD goes deep, and it really affects a lot of aspects of time management, planning, organization, etc. That is a problem that is bigger than performance. So I know I'm probably going down a rabbit trail that's way off your question, Dennis, but I do want to address this issue. So if your academic performance question, let me put your question back up here. If the academic performance issue has to do with ADHD, then yes, certainly Concerta can help with that. And it's a good option because it's one that you should only need to take once a day. I say should because there are some people for whom even the long-acting stimulants don't work for the for their full day. And so they may take a short-acting one later in the day to kind of get them through the rest of the day. But I do warn people about that sometimes people can expect that they should be on top form for 12 hours, and we're not really built to be top form for that long. I mean, our brains get tired. So back to your question though. So yeah, if your academic performance issue has to do with ADHD, yes, the Concerta can help. It's not going to necessarily fix it though. You can still have trouble even with the medication because of the executive dysfunction issues can kind of make it difficult for you with your time management and organization and planning and all of that. And the stimulant may not help with that. If the performance has to do with, I just want to be able to stay awake for a certain amount of time and stay focused for a certain amount of time, yes, stimulants can make anyone, whether you have ADHD or not, be hyper-focused for a certain period of time. I don't recommend, though, using stimulants for performance enhancement that is not related to ADHD because it can burn you out. It's like, you know, your mind and body has limitations, and if you try and push past those limitations artificially with medication, your body will eventually just say, okay, well, it's on you, I'm done. And then you can't think, you burn out, you get depressed, have tons of anxiety. All of these things can happen taking medication to work harder. All right. And I'm not saying that's what you're doing, but I wanted to address all of those because performance enhancement could be that's not what you said. You said academic performance. That could be a lot. There's a lot to that. So I wanted to address those. All right. Let's see here. Wow, we're getting close to the hour. I can't believe it's gone this fast. I'll go a little over an hour. I can't do 3 like I did last time. I already feel my throat getting dry. All right, let's see what I can get to as far as rapid fire here. Let's see. Here's a question about OCD from Michelle. I've been diagnosed with bipolar 2, OCD, and GAD. I've been off work for over a year, in the hospital 4 times, a lot of med changes, but nothing helps. My OCD is not like the usual things I have seen. Okay, Michelle. Gosh, first of all, I'm sorry you've had such a difficult time. I mean, 4 hospitalizations, that's big. Let me put your question back up. But you also have a lot going on as far as bipolar disorder, OCD, and GAD. That's a lot. And it's not going to be that easy to manage all of that. And here's why. So with bipolar disorder, you've got depression and mania. Antidepressants can sometimes worsen bipolar disorder, as far as making people cycle more, making people morph into mixed symptoms. Mixed symptoms tend to be a little more difficult to treat than having just pure depression or pure mania. And I do have some videos talking about the difficulty, or should antidepressants be used in bipolar disorder. So check that video out. So the reason I'm bringing this up is because I lost your question again. Let me bring it back up. Is that the standard treatment for OCD and GAD are antidepressants. Now, sometimes we can kind of cheat a little bit and use things like lamotrigine or Lamictal. Topamax is another one some people may use, Neurontin, to help with the anxiety, more the anxiety than OCD. So the anxiety problem, which are also treatments, at least lamotrigine is a treatment for bipolar disorder. Topamax really still has not been shown to be all that beneficial with bipolar disorder. But still, lamotrigine, it's a good drug, but trying to address someone's anxiety with it is plus minus as far as its effectiveness. Then, question back up, OCD itself has its own, it can be very stubborn, and it's hard to address and effectively treat OCD without behavior therapy. And kind of the main treatment for that is exposure with response prevention. I talk about OCD in a video that you should take a look at, and I talk a little bit about this exposure therapy thing. But the gist of it is that with OCD, you are exposing yourself to the things that you fear or have an obsession with, and making yourself not have your usual response. So example, let's say you can't get out of the house, you're late to work every day because you got to keep going back inside the house, checking to make sure you turned your burner off, checking to make sure you locked your door. You get to work and you've got to check your car door 10 times. If you don't check it 10, you're going to be super anxious if you go in. So you got to keep doing it, keep doing it, keep doing it, keep doing it, keep doing it. All right. With exposure, your therapist would come up with a more customized plan for you of how to actually do the exposure, because there's some nuances to it. But in a nutshell, you would you could create a situation either in your mind or an actual. The created in your mind is called imaginal exposure, where you perhaps are in a situation where you're not able to check something. This is just a rough example. And then you would hold back on doing the checking, and you would do things to address the anxiety that you feel. Part of what that does is shows you that you can live with this. You can live with the anxiety that you feel, because one of the things with both anxiety, GAD, and OCD is this fear that the anxiety is going to overwhelm you in a way that you're not going to be able to handle it. So you may avoid things so that you don't experience the anxiety. So this exposure therapy puts you in there and helps you live through it and get used to it and habituate to it and be able to manage it better. All right. So we're talking 3 different big problems that have 3 different kinds of treatment approaches. So I hope that your treatment is incorporating all of that. I know that that's easier said than done because treatment costs money. And so, and not all insurances want to pay for it. Not all therapists take insurance. So it's easy to say, just go get therapy. But I know that that's not always the easy answer here. But something I did want to say about that is, going back to my announcement, or not announcement, my news flash, if you will, at the beginning of this, talking about TMS. So transcranial magnetic stimulation is a treatment that started out being used for depression and now has a protocol for OCD. If you have insurance, I would recommend you look into that if you have not already, because OCD can be it can, as I mentioned, pretty stubborn, especially if you're addressing it only with medication and not with the therapy part. Sometimes it requires antipsychotics. And if you're taking an antipsychotic for your bipolar disorder, that could help with the OCD as well. So, I think that since at the end of your question, you basically say that your OCD is not like the usual. I'm not sure what you mean by that. My thoughts would be, or my guess, it may be that maybe you have some, you get close to the delusional level with OCD. The people with OCD that I've seen where it's unusual or not your typical or very difficult to treat is when some of the obsessions kind of get close to the line of delusions, or maybe even go over the line a little bit in this fixation on this thing. And that then leads to these behaviors. So that is where things like antipsychotic medications become important to include in the treatment regimen, even though that's not the usual for OCD. It's usually antidepressants alone. And many people will respond well enough to that. I say well enough because here's the thing with here's a thing with OCD, not the thing, is that I'll tell people that I do think the expectation should not be that you never have any obsessions or compulsions, is that they're reined in a way that they're manageable. So, for example, let's say you can never go to a restaurant because you are always focused on people touching things. And unfortunately now that's a real issue. But outside of pre-COVID, you can't go to a restaurant because you get so worked up about them, like the waiter bringing your food and having his thumb on the plate. And so now you've got to count 50 times in your mind. Sometimes people will have, when you talk about having unusual OCD, sometimes people's obsessions will be things like, if this person walks across the room to the left, that means that my first child is going to be kidnapped or something's going to happen to my grandmother. I mean, there's lots of thoughts that people can have that they don't even really feel comfortable telling people about because it sounds bizarre to them. But they can hold on to it and really believe it, even though it sounds bizarre, and therefore avoid, stepping on 5 cracks, because if you get to the 5th one, my house might burn down or something. So another rabbit trail. Let me get back to where I was. So going back to the issue of keeping your expectations reasonable. If I guess a clearer example for me. Oh no, going back to the restaurant thing. So with treatment, you may get to where you can then go to the restaurant and find yourself not even noticing that the waiter, the position of the waiter's hands when he brought the plate. But you could still think in your head, I wonder if his thumb touched my food. I wonder, but then still be able to eat. So it's not as though you never have thoughts of these things that you were focused on before, but it's just that you can get past it. You can still do things despite it or despite the thoughts. I think that's a more reasonable expectation of whatever treatment you have. Sometimes people will believe or hope that treatment will mean it's all gone and they never think this way anymore. And it's not that and I don't think that's reasonable. I think you can think these things, but you can still live with the thoughts and move on with the thoughts. And going back to what I was saying in a previous answer about having things going on in your head. Oh yeah, it had to do with the borderline personality traits. We can think all day long, but what are our actions? And the actions, the way we act is what matters, and how we relate to people, and how productive we are, etc. So, and that's based on, I was trained in a Freudian environment with psychoanalytically based concepts. And so, in that realm, you're thinking about the very primitive thoughts that we can all have that as we mature, we learn not to act on. But as we're younger and less mature, we act more on these primitive thoughts. So we can have lots of thoughts. It's all about how you're behaving, how much they control you, and how you're responding to them. Okay, what time is it? Oh, it's 12:04. Maybe one more question. I'll do one more question. Let's see. What do we got here? Lots of people saying hello. Hi, Megan. Yaki B. Han. Let's see here. I'm seeing lots of highs. Hi, guys. Maybe there isn't another question, and if that's okay, that's fine. Thank you, Catherine. I love your videos. Thank you from England. All right. If we got any more, let's see. Okay, I'll take this one last question from Olivia. I have a friend with bipolar 1, and sometimes he ignores me. What could be the reason? Well, Olivia, the reason may have nothing to do with bipolar disorder. And I'm glad you asked this question, and I'm glad I'm ending on this, because I don't know if this is what's behind your question. So I want to address similar questions that I think people have with this idea that bipolar disorder just means anything that somebody do that's off is bipolar disorder. I've had some people come see me for evaluation, kind of brought in by the scruff of their neck by a family member or something, and say, she's doing this and this and this, and I think we just want to know, does she have bipolar? And it's like, that has nothing to do with bipolar disorder. Like, bipolar disorder, if a person lies, that doesn't mean they have bipolar disorder. So, okay, I'm not going to go down a rant, but that's one of my beefs, the thinking that anything out of the norm or anything weird is bipolar disorder. All right. Again, I'm not sure. I'm not saying that that's how you think, Olivia, but that gave me the opportunity to put that out there. But going back to your question, though, of why would your friend ignore you? So let's say it is related to his bipolar disorder, because I said, he could ignore you for lots of reasons, but let's say it is related. One reason could be that he's depressed. Oh, wait, I'm assuming it's a he. I'm sorry. I don't know why I made that assumption, but I'm just going to say he because it's easier than they and all that stuff. So he could be depressed. If he's depressed, when people get depressed, they can get very withdrawn, not feel like talking. I mean, it's kind of hard. It's hard to relate to if you've never felt that way, but it can get to where it's just painful just to even it's like you just don't even want to face people. You don't want questions, because then people who really care about you, are you okay? And some people, even though that's well-meaning, that can still feel intrusive. Like, I just don't want to have to go there to tell you how I'm doing. Now, I'm not saying that's the right response for them to have, but that can be a response. Sometimes people can be so in their head with their thoughts and their ruminations and things that it can, you could be talking to them and they don't even hear you really. I mean, they can hear. There's nothing wrong with their hearing. I don't know why I'm looking over there. Sorry. There's nothing wrong with their hearing, but they're tuned out. So depression could be a reason. Now, sometimes people, and this isn't what you're referring to, but sometimes people can have some ADHD attention deficit hyperactivity disorder that overlaps a little with bipolar disorder. So maybe they have more than one and you just don't know their full, psychiatric history, or they don't even know. Maybe they have some aspects of ADHD. I did a video talking about how to tell the difference between bipolar disorder or mania, bipolar disorder and ADHD, because they can get confused sometimes. So if a person has some aspects of ADHD, they can do a tune out thing that's not deliberate. It's just things get filtered. So it's like you can be sitting right here talking and just be like doing their thing. It's like, did you hear what I said? And huh? Oh yeah, you said, and they may even pick up on a couple words that you say. They didn't really hear everything because they weren't paying attention. But they can pick up on a few things and kind of confirm, oh yeah, you said this, right? And then you could be left feeling like, well, why? I'm standing right here. Why are you not listening to me? Why are you ignoring me? And in that person's mind, it's not as though they're intentionally just saying, shh, talk to the hand. They're in a thought. They're in their own thought, in their own head. And everything else just gets filtered out and just sounds like wah, 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 wah. And some people are better at controlling it, and some people are not good at controlling it at all. And yes, that seems incredibly insensitive and rude and all of that, but it's just one of those things that can just happen and that person's just like that. I can't think of any other reasons related to bipolar disorder off the top of my head that could make your friend ignore you. One other. There's lots of reasons, but one last would be, let's say the person was hypomanic or manic. So they're in a state where they are, their mind's racing about stuff. They got this and that on their mind. They're going to do this and this and this, and they're busy. And they may look busy, but they may not look that busy, but their mind is super busy thinking about stuff. And similar to the ADHD issue, if their mind's super busy thinking about stuff, you could be talking and they don't even hear you or not paying attention. Or if what you might mean by ignore is not actual face-to-face talk, but they're not returning your text messages or your phone calls or emails, that could be more, that's more in line with what it could look like with the person who's actively engaged in their head with other stuff, either it be depression or mania or poor attention issues, and they just don't get around to returning text messages and things like that. They can see that they've got 20 notifications, but they're busy doing so many other things that they can't multitask at the moment. So those are just some kind of rough thoughts. I hope that addresses that, at least something of that touched on what you were asking about or what you're experiencing with this. Okay, I think that's it for me for today. Thanks a lot, guys, for coming. I really appreciate having you here. Lugman says, please talk about health anxiety. Lugman, I am in the middle right now of editing a video that I did on health anxiety, a part 2 to an original video that I did that was very long. And I'm doing another one, and it probably will be out in several weeks. So it's a little too much for me to talk about at the moment. And okay, let me just say this. And this still isn't really going to address your question, but I will say that one thing with health anxiety that you need to focus on is with health. This is in my house. Got people in my house. So sorry about that. I got thrown off now because that really threw me off. Oh, health anxiety is that with health anxiety, you have to be able to pull yourself out of the focus on your body and focus on the fact that this is anxiety. It just so happens that the things that you are focused on, like your racing heart or your dizziness or something is the way you manifest the anxiety. And that's hard to do. It's hard to pull yourself out of that. And I guess the only tip I would give you for now, which I talk more about in this video, is in eliminating some of the behaviors that reinforce that anxiety, like the checking, looking on the internet all the time, trying to research symptoms and see, is that what I have? Even though you've been told 20 times that that's not what you have. Because with health anxiety, it's not about getting a no answer to something. It's your anxiety, because the no answer of, do I have this? No. It doesn't last that long. The satisfaction you get from it doesn't last that long. So it's about addressing your anxiety. And in the meantime, like, how do you address anxiety? That's a big, there's a long answer to how to address anxiety. But a short answer for today is doing things to like practicing meditation, exercise, making sure you have adequate sleep. I mean, there's lots of stuff that you've got to piecemeal together. It's not just one, do this and then your anxiety goes away. There's a lot of work involved in it, in addressing your anxiety. But you could start with reducing some of the behaviors that you know you do, and maybe you don't know you do it. And so that's another thing that I guess my video can help you with when it comes out, is what are some of the things that you do that reinforce or make your anxiety worse, like checking, like getting reassurance from people, avoiding things that trigger your anxiety. So I'm not gonna let myself go over here or go to the grocery store because that makes my anxiety worse. But then you end up missing out on things because of the things that you're avoiding, or even become a hermit, in fact, because you've eliminated all this stuff out of your life. So that would be the place I'd start, is working on reducing reinforcing behaviors. And I may have talked about reinforcing behaviors in the first video that I did. I probably did. If I didn't, it'll definitely be in the next one. But you could also do an internet search on that to get more details in the meantime. So you could start practicing. Just pick one thing that you do out of the category of reinforcing behavior. So if internet searching is one, stop that or do it less. I know it's hard. Let me just check this one thing. But because at any rate, I don't want to keep rattling on about that, but that's where I'd start. Okay, that's it for real. I'm going to go. Thank you guys for showing up. I will try and do this more often. I can't commit to a frequency because I'm still, again, seeing patients. And these questions will be time-stamped. And since the chat gets saved, I believe, what I might do is try and address some of these questions in a different setting. I mean, I am not short. I have no shortage of questions from you all. And I love that. I love that you have questions. And I'm even considering some other formats for answering these questions in a more long form way. Hint, hint, maybe podcast. Because it's easier to kind of go on about that. The production of it is a little bit easier, answering questions in details. Anyway, just something I'm thinking about. All righty. So take care and stay well and have a great weekend. Bye-bye. Okay, I'm not going to say goodbye till I know how to turn this thing off. I don't even know how to stop it. Let me see. Oh, there's the finish button. Okay, one more time. Goodbye. Have a great day.